Good afternoon. My name is Monica Yanger with the Governor's Office of Health Transformation. Thank you for joining us for the episode's webinar. I'm joined by Dr. Mary Applegate, the Chief Medical Officer for the Ohio Department of Medicaid. We will be doing an overview of the episode-based payment, which is an innovation of Ohio Department of Medicaid in collaboration with the Office of Health Transformation, as well as commercial and Medicaid managed care partners around the state. Dr. Mary?
With that, I'll go ahead and continue. On this next slide, what you see is a graph of the spend in healthcare for Ohio compared to the rest of the country. And what you'll note is that we spend more per person on healthcare than, except for 17 other states. So we end up pretty much in the top quartile of spend and the bottom quartile of outcomes. And this is actually the reason we are embarking on value-based purchasing. We have two main ways that we're doing this. One is through an episode of care, and the other is through organizing the primary care delivery system, which you may hear a little bit more about later. In fee-for-service, all we get is what we pay for, which is an aliquot of time and a specific service, but not necessarily connected to making people better in their lifetime journey of health. The system was not designed to actually make people better. So there are lots of assumptions in that. And as we have created this very complex system and people over time have multiple comorbid conditions, we realize that coordination of the right services at the right time in the right setting doesn't happen automatically in a fee-for-service universe. So the only way to make more money is actually to see more people, and that does impact the quality of the care that's received. We also see a lot of variation. So even though in training, there are lots of commonalities, once folks have been out in practice for 10, 20, and 30 years, there's a lot of variation that diverges from the best evidence of practice. So there's no quality built into fee-for-service, and that's another reason we're trying to figure out a better way to pay for care. This next graphic actually shows the ways that we actually may pay for care that are different than fee-for-service. So the most common way may be through primary care, which I referenced earlier, and that's population-based. And that relates to the care of diabetes, hypertension, asthma, chronic conditions over the course of someone's life. The next way we pay for care is considered episode-based, in which we can have a very discrete set of definitions and pay for the entirety of that episode, from before you need the procedure until you're back up walking again, for example, after a joint replacement. What we have right now, based on a DRG payment, is a payment for, let's say, the joint replacement and the orthopedist and the hospital stay, but then there's another bill for complications for a blood clot, another one for a pneumonia or a surgical site infection, and this is all disconnected from the 3 MRIs before surgery and never really having transportation and making it to physical therapy, so the person ends up not really having the good outcome we want. In an episode-based payment, we define what the goal is and the most important pieces that actually get us there, one of which may be the procedure. It also ensures clarity around who's most responsible for that outcome, so that we understand who the leader of the team is. And then the very last way to pay for care is fee-for-service. So for very specific and unique types of situations with smaller numbers of patients, then we would have to pay fee-for-service. And some of the very specific congenital or rare conditions actually might fit in this case. So in our model, this is not just a Medicaid effort, just to be clear. I think across the country, many of you are aware that Medicare and multiple private payers also have episodes of care. On this page, we note the top payers in Ohio that are participating with us, so that our episodes of care are aligned with programs that they already have in place or that they're planning to implement in the near future. These plans cover nearly 90% of Ohio's population, which is about 20 million covered lives. So today, 4 objectives. 1 is a quick update on progress. 2 is to review thresholds that we have in place for episodes that we've already written. 3 is to provide another update related to the timing and details of reporting. And lastly, we want to share where we're headed going forward through Wave 3 episode design. We'd also like to ask for recommendations for additional participants if we haven't already reached out to you. This next slide shows the two main ways that we've innovated payment that I just reviewed with you. On the left side is the evidence-based payment. I won't read all of the detail here, but simply want to highlight that the patient-centered medical home, which organizes primary care, is designed to dovetail with episodes of care. So in essence, we're trying to reach 80% of Ohio's population through patient-centered medical homes, many of whom you already work with. And then instead of just paying fee-for-service, there's a per member per month that's risk-tiered based on 100% attribution, so that every Medicaid patient, for example, is assigned a primary care clinician and a practice with a risk tiering and a forward-leaning prospective way of reaching out and taking care of people before harm or poor health outcomes come to them. So right now we have 92 Ohio CPC practices enrolled for the period beginning January 1, 2017. Let me describe a little bit about how this works. So this program is called Comprehensive Primary Care. You may have heard of it already. There is an analogous one on the federal side called CPC Plus, but ours is just Ohio CPC. In order to participate, there are 8 activity requirements, which we took from all of the evidence in prior PCMH activities that were associated with positive outcomes. So things like same-day appointments, 24/7 access to someone who has your record and can diagnose and treat you, perhaps as a strategy to not only be preventive in care, but also to avoid unnecessary utilization of care. There must be a mechanism for understanding who's sicker than someone else, so that different kinds of services can be given. Again, in fee-for-service, it's basically one size fits all. So this risk stratification linked to population management is actually those are new terms and actually new functions of a fully implemented PCMH. Team-based care may be available now in large centers as well as academic systems, but not necessarily in smaller rural practices. But we want all professionals to work at the top of their license. So RNs, advanced practice nurses, physician's assistants, all can step up to help take care of the community in which the practice is located. Follow-up after hospital discharge is an important gap that needs to be covered, and having processes in the office to take care of that are important, just as it's important to follow up on tests like mammograms. The old, no news is good news is actually not the way we do business anymore, because if a test was appropriate and the person didn't show up, we need a way to track them down. Or if they actually had it done and the patient's waiting for you to call them, it's not okay to not be able to tell them what their good or not good results are. So that closing of the loop is one of the main activity requirements for this patient-centered medical home design in Ohio. And lastly, but certainly not least, is a focus on patient experience. So for what we've heard from patients is many of them don't find the health system to be friendly at all, and they feel a little depersonalized through the process. So in this effort, there are patient advisory councils that are required so that patients can have direct input into the patient experience. With these 8 activity requirements, we are expecting that practices are more efficient, and you can see the 5 measures here. Emergency department visits, inpatient stays for ambulatory sensitive conditions, generic prescribing, behavioral health inpatients, and we saved a space for episode-based metrics as we build those out. So you can see that once folks are calibrated to be efficient and effective in the delivery of healthcare, we should be able to achieve at least these kinds of process measures. And while these might not be outcomes per se, one might argue that being in the hospital for something that you could have taken care of as an outpatient, that could be considered a harm. So in essence, we're improving the quality of care. If this isn't complex enough for you, we do have an additional 20 clinical measures related to 3 different population streams: the care of women and children, the care of those with primary behavioral health conditions, and the care of those with chronic behavioral health conditions. So these are HEDIS measures that are all claims-based, and practices need to pass 50% of them. The very last thing, which my finance folks would prefer not to have be last, is the total cost of care. practices are expected to pay attention to the cost of care, not just the quality of care. So prior to this time, it was felt to be good enough to do what we felt was best without attention to cost, and we realized that value is defined as quality over cost. So unless the clinicians have some idea of the cost of the tests and medications and the treatments that are prescribed, it's hard to get to value. So we've lined up these 4 main requirements so that we can really purchase all of these as the value in healthcare. I referenced briefly that the payments are per member per month, which is in addition to the fee-for-service, and that allows the practices the freedom to use community health workers, care managers, different kinds of personnel, and IT solutions to try to achieve these efficiency measures. In addition, there is a shared savings based on self-improvement as well as performance relative to peers. And that's true only if the practices pass the quality gate. So if you're saving tons of money but no one's getting care, that actually won't work for us. So in brief, that's a 2-minute snapshot of the entire comprehensive primary care effort with which you will be interfacing. Now we'd like to spend the rest of the time talking about episode-based payment. So we've done 13 episodes across 7 different categories or subspecialties with clinical advisory groups. We have 30 or more under construction at this time, which we're hoping to launch later this year. We have 9 payers that have released reports, and we have set thresholds for performance, both for fee-for-service as well as Medicaid managed care. So I think with that, I'll actually describe the basic tenets of the episode-based model. So first of all, this is a retrospective model. When patients come to you, you still see them, you still submit your claims in a fee-for-service way. But what happens is, we'll pay the claim, but afterwards, we will review the claims according to predefined standards. And one of those standards is identifying the principal accountable provider, and that is the entity who is in the best position to be able to guide a good outcome for the patient. So for example, for a surgery, you can expect that most of the time it's going to be the surgeon. So we identify who the principal accountable entity is, and then we calculate the average risk-adjusted reimbursement per episode for each of these accountable entities. What results then is a distribution graph. We have a tiny little image here. I'll show you a more detailed one in a moment. And we compare performance for that year across the entire state. With this, the providers may share savings if their average costs are below the commendable levels and they meet their quality targets. There is a negative payment incentive if average costs are above the acceptable level. But what you may see is that for the majority of folks, there may be no significant financial impact. In fee-for-service, you might ask, why are you doing this if half the people see no impact? Well, in fee-for-service, there's absolutely no way to get paid more for doing a better job, and there's also no negative consequence if you're not practicing evidence-based medicine. So this actually allows us an infrastructure to be able to reward quality. The next graph actually shows more detail. This is a traditional PAP curve, which you all have seen a number of times probably. The bar corresponds to an average episode reimbursement for any given PAP. The providers above the acceptable line incur a negative incentive payment, and those are folks on the left there that you see in red. However, for the bulk of providers, they're in that gray zone, so nothing changes for them. You will note that there are providers below the commendable threshold that actually do not meet the quality metrics, so they are not eligible for any kind of positive incentive. Here, for illustrative purposes, you see that the blue bars are providers that didn't pass that compared to the green ones who did. So that way you can get an idea of how this works. What happens is if you're below the commendable bar and you have met the quality metrics, you get to keep half the difference. And while this looks like a small amount on the graph, imagine over the course of the year and the hundreds of patients you may see, this can actually be a sizable amount. We have categorized our episodes, as you can see here, because the main episode that folks think about are simply procedures. But much of our inpatient care is actually not specific to a surgery or procedure. So first we have planned procedures. which may or may not be specific to a condition. And examples here include joint replacements as well as coronary artery bypass grafting. We have other acute procedures, such as heart cath or a perinatal delivery, a maternity episode. And the typical PAP there could be the obstetrician, or it could be the facility as well. We do have acute emergent conditions as well. These tend to be unplanned. And during those circumstances, the facility is often the typical PAP. Examples here might include acute asthma or GI hemorrhage, because the facility is where most patients receive care. Next, we have acute non-emergent conditions, and this may include a spectrum of care from primary care offices to the emergency department, for example, and the clinician is usually the provider here. So examples include upper respiratory infections, UTIs, otitis media, anxiety or depression could fit in this category as well. Our next category is acute symptomatic treatment. Here, typically, the provider at the facility would be the PAP. Low back pain and headache might be examples in this category. And then lastly, we have chronic conditions for long-term disease management. And typically, the clinician is the PAP here. These episodes could last a fairly long time, for example, 6 months. So you see ADHD, attention deficit disorder with hyperactivity, as well as oppositional defiant disorder might be an example of this as well. Next, I have the laundry list of all of the episodes that we've either done or that are in progress at this time by the categorization scheme that I just reviewed with you. I'll give you just a minute to review that instead of reading it for you. Okay, since you've all probably memorized that, now what I'd like to do is get into the nitty-gritty detail as to what an episode is and what all the components are. So when we do this episode, we have to figure out what triggers the episode. So we must define it. So for example, if it's a joint replacement, let's say it's your joint replacement. But what do we include before the joint replacement, and what all is included afterwards to actually have this hang together as a positive outcome for the patient? So that definition is the episode trigger. And that's a diagnosis or procedure and all the claims that come with that, including the facility claims. That would be how we define this. So we have to remember that our data source here is actually claims-based. It's not something that you have handwritten or typed into your electronic health record. So it's important that we look both at professional claims as well as facility claims to be able to correctly identify the trigger. Then we have a pre-trigger window, and that's the time period prior to the event with relevant care. So let's say this is a joint replacement. What are you going to do with the chest pain and the GE reflux and all of that ahead of time? Those other diagnoses are not central to your joint replacement, so that's not necessarily what you want to capture in that pre-trigger window, but you do want to capture pre-op testing, MRIs, and that sort of thing that are directly related to your trigger. The trigger window itself is the duration of the potential trigger and all of the care that is included. ICUs, different parts of the hospital, that's all in there. The post-trigger window is the time period following the trigger, and that includes all the relevant care as well as complications, potentially including the nursing facility. So this gives the clinician a view, a broader view than what they may have if we're just looking at the hospital as the site of service. The principal accountable provider we referenced before, and this is the clinician who may be in the best position to assume the main accountability for all of the decision making that will influence the outcome for the patient. So many of the clinicians are hired by facilities, or there may be aspects of the facility such that the facility itself could be the principal accountable provider. So just so you have a sense of that for the different episodes. Next, we have quality metrics, and these are measures through which we evaluate the quality of care. We also have potential risk factors, and these are patient characteristics, comorbidities, other diagnoses or procedures that indicate that the patient's at an increased risk for any given episode. It's important to identify risk factors because we want to compare PAP across the entire population, so apples to apples or oranges to oranges if you must, and doing risk adjustment allows us to get to that. In addition, we realize that there's some factors that we can't risk adjust for, so we simply have to exclude them. These might be patient characteristics, comorbidities, diagnoses. It could be related to how we get claims and whether or not we have complete information for them. So you might see that we have a number of business exclusions, and that's in an effort to actually have comparable populations by provider type. So given all of this, a way to understand episodes is actually to simply take you through the patient's journey. So as an example here, I have a perinatal delivery, and what we expect to see for an episode of care for a delivery is that over the 9 months preceding the delivery, the mother received her prenatal care, her screening, all of the testing. We've taken into account patient-centered medical homes and the timeliness of the first prenatal visit, for example, and there may be a number of supportive services, including counseling and education, that's included in here. Then we get to the delivery. This is where most of the costs are incurred. Deliveries are either vaginal or by C-section. There might be other procedures that are included at this time, including anesthesia, episiotomies, et cetera. In addition, there are supportive services that are provided within the inpatient setting. Next, the mother then moves to the postpartum care time frame. And at this time, the ideal is to have the mother be seen for follow-up visits, mental health evaluations, referrals, education, support for breastfeeding, follow-up on hypertension and gestational diabetes, and any sort of health planning related to contraception. We do note here that if all of this happens properly, we have minimized complications. So we certainly do see complications of bleeding, urinary issues, depression, readmissions. On the next slide, you'll actually see that we've called out sources of value using the same grid. So in essence, we want to see an appropriate and effective mix of prenatal care. We'd like to reduce elective interventions such as early elective deliveries or C-sections if appropriate. We'd like to make sure that the mothers stay an appropriate length of time in the inpatient setting. And we'd like to improve the number of women who actually show up for postpartum visits for planned care. We're hoping that all of this not only results in a healthier baby and mom, but also unnecessary readmissions. Okay. Next, what I'd like to do is just take you through the definitions that we reviewed generally before for this perinatal one. So the episode trigger is the delivery code. The pre-trigger window is 280 days, 9 months ahead of time. The trigger starts on the day of admission for the delivery and ends on the day of discharge, and extends through the postpartum period, which is 2 months later. All of the claims are included relevant to prenatal care, including all the complications. We did exclude medications such as progesterone because that added unnecessary and very costly variation for just a fraction of the patients. In the postpartum period, we have all complications and care there as well, including readmission. The physician or the physician group responsible for the delivery is the PAP, and for quality metrics, only some are tied to gain sharing. The others are for reporting purposes only because we're aware that a lot of clinicians don't actually have knowledge of their entire population or their entire practice. They only know what they know anecdotally from the individual care they've provided for these women. So linked to gain sharing, we've picked very obvious evidence-based standards. So here we have prenatal HIV screening, prenatal group B strep screening, C-section rates, and the % of episodes that actually have a postpartum visit. Clinicians expressed interest in knowing the number of episodes for women with gestational diabetes for which they actually had a repeat testing done afterwards. There was interest in hepatitis B as well as STI screening, as well as ultrasound rates. So in the reporting section only, you'll see areas that have been identified that have high variation across the entire state. Risk factors include comorbidities, so you can imagine hypertension, diabetes, substance use, obesity, et cetera. And exclusions include conditions which make the patient's journey significantly different in the types of care provided or the costs. So what you see here are very special conditions: cystic fibrosis, cancer, needing dialysis, HIV, someone who's paralyzed. Business exclusions include dually eligible or inconsistent eligibility. So if someone doesn't have insurance or we don't have their information, we can't do this apples to apples comparison. For this particular episode, there are age cutoffs. so less than 12 and over 49, just related to the definition for reproductive age. And we also exclude folks who die or leave AMA. So now I'm going to take you through the math. So if you do all of this and line up all of the packs, this is what the costs look like, with the high-cost providers on the left-hand side and the very efficient providers, or those who might have been on call just for delivery for someone who had no other care, on the very right-hand side. So what you see is that there's a pretty big difference in average cost. Next, what I want to show you, though, are the kinds of factors that go into exclusions, and I referenced these earlier, either not having their information from a business exclusion or being so different clinically that it's not the same patient journey. So next, I'll actually show you the graph related to that when we take out exclusions. The other thing that we took out in this particular graph is the impact of medical education and capital expenses, and that has to do with hospital costs. The graph after this actually shows risk adjustment. So in order to not penalize high-risk clinicians or to disincentivize cherry picking, you notice that we have a number of patient and other factors that may weigh into the cost of care. So here's a list of many of them on the list. I will also note that any individual who has 3 standard deviations higher than the risk-adjusted mean gets excluded as well. So if you have someone who after delivery was in the ICU for a month, that's not someone who would actually be counted in your episode of care. So once you risk adjust, on this next graph, you actually can see what happens. So in the light gray was that original graph I showed you, and here you can actually see the spreading cost across the entire population. And even though it's a fairly flat line, there is a curve to it. So I wanted to point out here that this is actually a statistical model that we're running across the population as a way to manage the health of the population. Okay. Next, I'd like to give you an update on Wave 1. So here's the timeline of how we did episodes. In Wave 1, we started the design in mid-2014, and 2016 to 2017 was the first performance year. So this is for newborn episodes like the one I just discussed, but we also have asthma and COPD. We had a couple of other episodes in there as well, as total joint replacement, heart cath, for example. In Wave 2, you can see we're a year behind Wave 1, and this is where the upper respiratory infection, UTIs, APIs, colis, and GI procedures fall into line. And then you can see this huge list in Wave 3, and that's actually where we are with spinal fusion and decompression surgeries. You'll see here a number of orthopedic episodes and very common chronic condition episodes like congestive heart failure, diabetes, soft tissue infections, for example. So here the design year was last year, and this year we're doing reporting only with the performance year starting in January of 2018. We are intending to take on behavioral health as a wave after that. So if this sounds overwhelming, one way you can think of this is we're trying to create a way to provide the clinicians and health systems feedback as to the health and healthcare utilization of the population that they serve. Now, because we're using Medicaid as the database to start with, in the beginning, for Wave 1, we only linked asthma, COPD, and perinatal to payment because our numbers were actually not high enough for heart cath and joint replacements. You might imagine that the Medicare population has a much higher volume in those spaces. We also changed how we report. Initially, when we started, every single managed care plan did their own report, and we've realized that clinicians really need to go to one place and just click on which plan they'd like to see with an aggregate available for the entire Medicaid population they serve. Here, what I'd like to show you is what our performance looks like across the system, which we don't necessarily appreciate as we take care of patients one by one. So the idea in these first 3 episodes, and I have summarized here the different quality metrics, the idea here is actually to do better than the performance of the system. We set our initial thresholds so that 75% of all the providers pass the metrics tied to payment. And what I'd like to point out is what that means is if you have an asthmatic, what you notice now is only about a quarter of the asthmatics are on controller medications, which we know is the best evidence of best practice for a chronic condition. So we think that all of the clinicians out there can do better than missing 75% of the mark. For perinatal, for example, our C-section rate is 45%. That's almost half. We think all of the obstetricians and health systems out there can do better than a C-section rate that's quite this high. The other thing I'll point out is only half of the women ever get seen afterwards, when again, that's one of the best opportunities at a critical time of a family's life. So we think we can do better than that. So we started with this, what does it take for most people to pass? And over time, we'd like to ratchet that up so that we're in the top quartile of performance, hopefully across the country, compared to that bottom quartile that I referenced at the beginning. The ratcheting up happens over a period of 5 years. It's not sudden, and we'll take into consideration systems transformation and current performance as part of that process. So next, I think to talk about some of the finances. Oh, I have one more slide before I hand it back to Monica. Here, I'd like to show you what some of the feedback to the clinician looks like. So for all of the episodes of care, the PAP will get a report that actually looks like this. We have a lot of detail as to where to get and how to get your report, and Monica will talk about that in some detail. But essentially what you'll see is the pie-shaped chart that tells you of all the deliveries you had, how many are actually included or not included, because you could be a high-risk obstetrician and have the majority of your cases excluded by virtue of the factors we just talked about. Then you see a very specific and individualized path curve with a dark green line where your current performance is. So luckily for you, you're actually on the good side of the graph and you may be eligible for gain sharing here. Then you see quality metrics, and they're color-coded as to green or red as to whether or not you're passing them. So I had mentioned there were 4 in this particular one, and at this time, this is dummy data. The person is passing 2 of them, but not the other 2. So there's an opportunity to find out, well, who do you need to chase down to make sure they come to a postpartum visit so that you can actually pass that metric. And then on that bottom side, there's actually a graph related to the spend, related to this episode. So with that, I'll actually hand it over to Monica, although I do want to comment that as we have embarked on all these episodes, the attention to quality metrics has given us some insights. So for example, when we did the ADHD episodes, we realized that there was a lot of prescribing for very, very young children when that's actually not the best evidence care. We also came to appreciate, for example, enormous variations in new opioid prescriptions, particularly for orthopedic episodes, and there are several of them, whether or not there was a procedure associated. And then third, we realized when we had a measure related to the timeliness of intervention, we realized that the coordination of care is often multiple people's responsibility, which means from the patient's perspective, it actually may not happen. So this is one of the reasons that episodes of care can be useful, not just for the clinicians involved in that specialty, but also for the primary care clinician who's trying to help manage the entire health over a long period of time, before and after deliveries or procedures. Okay, Monica, off to you.
Thank you, Dr. Mary. So let's talk a little bit about the reports and the data itself. The schedule for reporting very closely ties to the timing for distribution of incentive payments for the Medicaid program. The performance information is a full calendar year, so 2016 for the performance period, and that information will be released at the end of roughly May or June, actually, of this year, so 2017. And this is due to the fact that at least 3 months of claims run out is necessary prior to running the episode algorithms. And so on the next set of reports, principal accountable providers, particularly for asthma, COPD, and perinatal, will see that there's a link to payment and a preliminary view of whether or not they're eligible to receive a positive or negative incentive payment. And then another report will occur in August, where principal accountable providers will receive a follow-up report allowing for a full 6 months of claims run out with the final positive or negative incentive amount, and then within 90 days, payments will be assessed and distributed. Let's talk a little bit about thresholding. So for Medicaid, including all of the managed care plans, there is a single acceptable and single commendable threshold set for each episode. The acceptable threshold was set such that 10% of providers are above the acceptable threshold and eligible for a negative incentive payment. Then the commendable threshold was set such that from the program-wide perspective, it would be budget neutral, assuming there would be no change in behavior. So the same methodology was used for asthma exacerbation, COPD, and perinatal. So the historical data was used to inform the threshold for these first 3 episodes. So an inflationary adjustment was applied based on inflationary factors identified by actuaries and used in the Medicaid managed care plan rate setting process. This inflationary adjustment takes into account both fee schedule and policy changes. So you'll see here in this slide the threshold values applied for those 3 initial episodes, asthma, COPD, and perinatal. They incorporate the inflationary adjustment and are based on risk-adjusted episode reimbursement. So this is not what a provider is typically paid in specific services included in the episode. So you will notice that the positive incentive limit is set at a very low level. Again, keep in mind this is based on I think the average of the lowest 5 episode cost that is risk adjusted. So again, this is not actual spend, this is risk adjusted. So a little bit about Wave 2. So 2017 is a performance year for these next set of episodes: cholecystectomy, colonoscopy, EGD, GI hemorrhage, URI, and UTI, and then appendectomy. You will notice that the first 6 are linked to payment for positive and negative incentive payments. The appendectomy is an informational-only episode. Again, that is due to low volume in the appendectomy episodes for the Medicaid population. So for now, Medicaid providers will receive an all Medicaid report with data aggregated across all of the Medicaid managed care plans, and the report, again, for appendectomy is informational only. Here are the quality metrics for the Wave 2 episodes. Medicaid has taken that same approach for the methodology for setting the Wave 2 episodes as it did for Wave 1. Specifically, quality metrics were set such that 75% of principal accountable providers passed based on historical data from calendar year 2015. And you can see the quality metrics here. One thing to note, originally the metric linked to payment for colonoscopy and EGD was % of procedures performed at a QCDR participating facility. As noted in all of the provider reports that have been delivered to date, there were data limitations, and Medicaid has not been able to report on this measure. Given this, the ED visit rate is now the metric linked to payment for these 2 episodes. Again, same methodology was applied to the Wave 2 episodes as for Wave 1, such that 10% of the providers are above the acceptable threshold and eligible for negative incentive payment. And the commendable threshold was set such that from the program-wide perspective, it would be budget neutral, assuming no change in behavior. Threshold values for the Wave 2 episodes shown here. They're labeled draft because they do not yet incorporate the inflationary adjustments as they did for Wave 1. Again, please note that these are based on risk-adjusted episode spend versus what a provider is typically paid for the services. And here's a screenshot of a sample report for the Wave 2 episodes. This is the cover page, which lays out each of the plans for a given principal accountable provider where a provider had at least 1 valid episode. They receive a report. So it allows you to click on the link to a plan and directly go to the page in the PDF where that report begins. Reports were included in a single PDF based on feedback we received from providers. So, and just so you know, the MITS portal administrator is the person with the access to pull down the reports. By having everything in one document accessible to you can streamline the process of someone accessing the reports and then sharing that information within the organization. So again, I mentioned that it is the MITS portal administrator that has access to the reports. This is one of our most frequently answered asked questions. This is a screenshot of what the person logging in will see. Note that it is typically an administrator in the practices that has access, and the MITS administrator can log on and download all PDF and CSV files and then share them with others within the practice.